So I'm going to talk about the latest treatments for melanoma. Again, we've been doing this for a number of years, working with Worth at AIM. And as I get into this, my disclosures, we worked with some of the companies to do some of these new trials and treatments that are available now. We've been actually, this is our 6th program actually. And so many things have changed in that short time frame that I'm going to kind of walk through with you today, and then kind of end on where we are, what's happened in the last year or so. So I'm going to take you back to 1997. For those that know me and have seen some of my talks, I've talked about this in the past, but it's been a long time. So this is the story of Joe. He is kind of a equally parts kind of tough fireman running in a fire with no mask, because apparently that's what you did, but also kind of part goofy. He had was cruising along in his life, apparently no medical issues. Around 1997, started developing headaches, confusion, a little bit off, although he's goofy, so what's the difference, right? But this was different. He kind of progressed, eventually got worked up, including imaging of his brain. And he had multiple bleeding lesions in his brain, so which was concerning for cancer. Unfortunately, there wasn't really much other spots to kind of go after, so they ended up having a brain biopsy. And unfortunately, that showed melanoma. No one quite knew that he had melanoma. Apparently, some years before, had something on his chin that was taken off. He might have taken it off himself, as far as anyone knows. But unfortunately, again, it went to his brain and caused a lot of problems. And unfortunately, he also didn't really recover just from the biopsy, and died fairly soon thereafter. Joe is my my children's grandfather. Not my story to tell, but it did start me kind of on a personal and professional journey as I was a third-year medical student. In the subsequent 13, 14 years, unfortunately, nothing really changed, including me in that field and trying to kind of change that narrative. And I apologize. I do have some curves that I'm going to show of how people did. And, this is the survival. And the survival, as Sam mentioned, is very poor. 6 to 8 months actually with stage 4 melanoma. Again, over an extended period of time, without much change, very frustrating. Things started to change in 2011. So a lot of people working on a lot of things, and we tried many new therapies and trials, and it just didn't work. But in 2011, we started to see some differences. I'm going to take me off of this. And really, those two major developments and discoveries were targeted therapy or cancer genetics, specifically in melanoma, BRAF, and immune therapy. And immune therapy has been of interest for a long time in melanoma, but really it kind of worked occasionally, but not great in melanoma. But some new discoveries really changed that. And so actually that was around in 2011 was our first kind of AIM talk. So that was a time when BRAF really was the thing. I mean, we're crazy to see melanoma kind of spread throughout the whole body, just kind of melting away. I mean, it can't really be overstated to see that happen. That has never happened in melanoma. And so a lot of excitement surrounding that. And I was excited, relatively junior-ish, wanting to talk about this. And so I was all excited. I was like, I'm going to explain cancer genetics and how cancer develops. And some of you may have even been there for this unfortunate talk of mine. But I tried to explain this to people. And it really was incredibly confusing, even though I was so excited to tell people. And most of the reaction was this. I'm excited. What do you mean? You don't understand that? So my senior colleague at the time talked about immune therapy, which people actually liked. And he gave me some advice. And he also gave me a slide, which is this. Whoop. So his immune response to cancer, and a little Pac-Man theory, that the immune cells, your own immune system, can get rid of melanoma. So you're going to see a lot of Pac-Man here in my talk today, try to explain where we are and where we're going. So 2013, it was this promise, right? It was just building up, really excited. as it's evolving, not just like we had these discoveries, but we're starting to see additional discoveries and a movement and people finally doing better. And so some of that discovery, again, was focused on immune therapy, was this kind of discovery of the shield or a checkpoint in melanoma. And so it basically puts up this block against your immune system that it doesn't allow your immune system to work. And that tumor just continues to grow, unchecked, if you will. But immune therapy that was developed really was these checkpoint inhibitors. And so these antibodies, basically treatments that can kind of take away that block, kind of took down that shield and allowed your own immune system to work. And you can see pretty dramatic responses in the power of your own immune system to get rid of the tumors. So again, moving forward into 2014, there was we participated, most of our focus is in running these trials and providing these to people. And so nivolumab and pembrolizumab, you may have heard of these, you may be on these, you may have had them, Opdivo, Keytruda, and then the combination the following year of ipilimumab and nivolumab. So it's certainly very exciting. And there were more therapies to come. It's really kind of an avalanche. In fact, if you talk to anyone in the oncology world, it's like they want to be in the melanoma space because so many things just went from like really one of the worst cancers to multiple. Every year, it seemed like something was happening. And not just a little bit. I mean, pretty dramatic. And so different approvals that were out there, including a therapy where you kind of an immune therapy inject into the tumor, all of these things have just kind of all out there, and we're trying to figure out how to best kind of manage that. So just to kind of illustrate a little bit of that, I'm going to talk about KC. So the melanoma on its side in 2017. Unfortunately, despite taking this off, this recurred, had surgery, and then put him on therapy with the brafenib and trametinib, which you may again also be partly familiar with. But unfortunately, despite that therapy, is spread through his body. And if no one's ever seen these, it's a PET scan, some version of a PET scan, with a lot of the all of this black spots being melanoma in the middle of the chest, melanoma around the lungs, and in the lymph nodes in the chest wall. And again, we went back in time, and not that long ago, 10 years or so, might have had 6 to 8 months to live. Thankfully, again, we've been studying these things and have a decent amount of experience with them, that he was offered ipilimumab and nivolumab, which he tolerated very well, which is not always the case, but thankfully he did. And in 2021, his PET scan had complete resolution of all sites of disease in 2021. And he continues to do well, actually in 2022, knock on wood, and that's expected to actually continue. And I say that because he's here today, here to tell his story. And I apologize, I took some of the thunder, but he'll tell you more in detail of his story. And again, here to entertain you, so he says. And he looks a little bit better than these pictures, although not much. Okay, so the next several years is really kind of following people over time in these therapies. And I apologize again for these curves, but this is kind of the reality of that, is that these are, again, the curve is over time, the percentage of people of how well they do. And this one is survival for melanoma. And so it doesn't work for everybody, unfortunately, but if it works for you, that could be a long lasting effect. And what I focus on and why everybody in the cancer world really is focusing on immune therapy mostly is because if it works, it can be a long lasting effect and potentially, in my opinion, curative if you can see it disappear. And so this is the characteristic curve, or what we call a flattening of the curve. So you're some years out with no disease. Even you can notice that early if you're responding, you might be in that category, and this continues. And I know this symposium is called Living with Melanoma, but I would argue that it's really living without melanoma. There's no disease, and the likelihood of recurrence is very, very low. Again, these are not promises to that, but this is the reality that could happen for some people. Obviously, still have work to do because a decent percentage of people it still doesn't work for. So again, fast forward to now. Again, where are we going? What do we do with all of this stuff? And so I'm going to talk. This is kind of a summary of all that's out there, really. So when do you, how do you mix these, or what do you start with, or it's just kind of people's heads spin. So we do our best to kind of counsel people on what would be the best. Sometimes you hop between different things. And in most of this, again, this is for stage 4, different situation for stage 3, but I'm going to touch on that a little bit. So the questions I want to address here are some new questions and topics that have come up. One question is when to treat. There's a lot of issues in that, and with earlier stage disease, later stage disease, what do you start with? Again, with all these different options, what do you do? And some data on a new therapy. So the first thing is when to treat. So the standard thinking in cancer, I would say, is earlier is better. I had given a more extensive talk on this concept, but the bottom line is it's not so clear, in my opinion, that doing it earlier, particularly immune therapy, is necessarily better. The concept of that is that you have a tumor in your immune system can recognize that if it's of a certain size in particular, I would say. So if it recognizes it, it can engage, tell its friends to kind of come along and then get rid of the tumor. Well, the downside is if there's something very small, and you can argue, or you can think about like an infection, you get a couple little COVID particles around you, it's not going to do, your mind's not going to do anything. It's just going to be there and move on. And if it's really small, you could say for melanoma, let's say, or cancers in general, if they're super small, then your immune system may not even recognize it. It kind of go along, and then that tumor is there and can potentially grow. But we don't know actually how much is enough. Do you need, 1 million cells, 1 billion cells? Does it need to have spread through the body? What is that? And so a lot of the research and interest is in figuring that out. And there's a lot of different ways to kind of determine if your immune system is activated and those kinds of things. So that's certainly of great interest that will be happening over the next years to come. Again, a little bit of data. So this is a trial, we call it S1801, which some of you here might have participated in, and certainly online may have participated in. This is a trial basically trying to test that hypothesis. Is if the tumor is in place and you treat with immune therapy, could you do better? So this is a trial where half the people got some immune therapy before surgery. This is when people had a melanoma kind of that you could see and feel, versus those that had it taken out and then had immune therapy. And at least for this, suffice it to say that the patients who had immune therapy while there was something there did better. Most of this is recurrence. So we don't have like long-term survival of people living longer, so we don't have that data yet. But it does look like it has a better activation of your immune system, and that may last, for an extended period of time. So this is new data. It's not been published yet, but it is been presented, and we'll see how it evolves and how this data evolves over time. Again, conceptually, if your immune system is there, it can be activated, and you can eliminate the disease. Okay, the second question is, if you have a BRAF mutation, what do you start with? I mean, you have incredibly, you can make this shrink, you make it disappear. And, it's hard to overstate, again, like a lot of community docs have told me, like, look, you have a melanoma, you have a BRAF mutation, I can make this thing shrink almost everybody. And so, you can't overstate that. And so we give those therapies. But the reality is there was no data. We kind of pushed in the academic world more immune therapy, but we didn't know. But there is data now, at least to support what potentially to do. And again, you can blur your eyes. I'm just trying to show the separation a little bit in the two groups of people. This is a trial where half the people got the BRAF MEK inhibitor, darafunib, half the people got a combination immune therapy, ipilimumab and nivolumab. And this is stage 4. And at progression, as it grew, you switched over. So that's testing, again, what you would start with. And the only thing I really want you to notice is that there's a separation in how people live longer if you were to receive immune therapy first. So again, this is the first data for that. And I think, for me, finally, there's data to actually show that immune therapy might be preferred as a first therapy. But again, nothing is universal. So there's still scenarios where you would do that, where you would do this targeted therapy, if you will, including people who are pretty sick and they can't even leave the hospital. So you basically have to do the BRAF MEK to make it shrink so you can feel better. And the reality is, including some people here who have been on these therapies with no disease for many years. And I have a handful of people who have been on these therapies and we stopped them after that and continued to do well for many years, actually off of the therapy. So again, there's still kind of a subgroup of people that still can do very, very well with that targeted therapy. Again, so the summary of that is the immune therapy might work better if there's something there to go after. And in general, as a general statement, immune therapy should be considered first, even if you're BRAF positive for stage 4 melanoma. Okay, and then the new therapy that's out there, a new kid on the block, relatlimab and nivolumab are up dual leg. So again, these shields are up as a concept. So one of those shields is, if you will, CTLA-4. So that is the treatment for that is ipilimumab. The PD-1 you may have heard of. That's the one that pembrolizumab and nivolumab go after. And there's many others actually. And one of those others is LAG-3. So that's another shield that's up. And again, treatments have been done against each one of these kind of checkpoints, and now LAG-3. And so when you do these treatments, you kind of take down that shield for each one of these. And now what we've noticed when you take down LAG-3, at least in melanoma, that you can unleash your immune system and it can go after the tumor. And it appears similar to the others now that it could eliminate the disease. So this is a story of another patient just to kind of illustrate that. So 2015, and melanoma on her side. Unfortunately, in 2020, had blood in her urine, and the melanoma actually had spread to the bladder. And the PET scan, similar to previously, you can see kind of relatively widespread disease, through the body. Interestingly, this was at a time when we had options. We could do other combination therapy or single agent drugs, but there was a promising agent, which is this relatlimab, and specifically in combination. And so we were testing to see if maybe this is going to be a little bit better than nivolumab, and maybe certainly the initial data suggested maybe a little less side effects, as some of you have been on ipilimumab, nivolumab, and can be pretty toxic. But this is a difficult discussion, and I've given actually one of the AIM talks was about clinical trials, and it's pretty involved, complicated story. But after long discussions, she agreed to participate in the trial, and was randomized, blinded, not knowing what you got, to again either relatlimab and nivolumab, or nivolumab alone. And she also tolerated it pretty well with some issues. And if you've heard this story before, hopefully it'll continue. In 2021, had a pet with no evidence of disease. All sites of disease had completely disappeared. And again, this is in August of 21, but this continued. Saw her not that long ago, and still has no disease, knock on wood. She is not here today to entertain you, but I think that's pretty entertaining. Okay, and we updated some data again with the trial at our annual meeting this year in 2022, and it was approved within the last year as a new agent and a new option for people with unresectable or metastatic melanoma. So the story, and thankfully the journey continues, and with more options. So the bottom line, though, is just appears to be a little bit better than nivolumab, possibly fewer side effects, which is where the important piece of that, and a few less side effects that we can tell from ipilimumab and nivolumab. Again, that's the main kind of difference, is maybe a little bit of a bump, but may not have the toxicities that the other combination does. There's no kind of head-to-head comparison, so it can be, again, fairly complicated. And so we're just adding it to our armamentarium of options for people. And if you came here to think what I'm going to tell you the answer of what you should do, I'm not going to, unfortunately, but it's a good problem to have when you have all these different options of what therapy to do. And so I'm going to cop out, I'm sorry, and tell you to ask your doctor. And again, just a couple last slides. One thing that will never change, and actually was in my early part of my career, was more in prevention and what called chemo prevention. Because regardless of the cancer, prevention and early detection will save more lives and eliminate and have a best impact on disease overall. So my kind of public service announcement to continue the push to help with prevention and early detection. And particularly in melanoma. There aren't that many cancers actually that we know the cause of, and certainly a large percentage, and certainly melanoma of the skin, we can potentially prevent. So the journey continues. I am one of those people that do believe that melanoma is potentially curative. If anyone, my patient, my intent when we first see you, my intent would be to cure you. because I think that's a possibility. And we have many patients to show that over time. That's not a promise, but that is a definite possibility for people. But again, the journey, it doesn't work for everybody. So the journey continues in honor of Val and her family, with Joe, and the many other Joes, unfortunately, that it doesn't work for or it hasn't worked for. So we keep moving forward for them, for you, and that's all.